Hey folks, Weingart here, and this is an EMCrit We. Today it's a case report from one of my buddies and colleagues out in Canada, Mathieu Brunet. He is an emergency doc, a resuscitation doc, and a trauma team leader. And he wrote me with a case of a fail during transcutaneous pacing, and I thought it would be interesting for the audience, so I'm putting it out there. If you have any comments, thoughts, or ideas about this, put them in the comments for this episode. Super curious to hear your thoughts. Let's roll right in. Who you are and what you do.
My name is Mathieu Brunet. I'm an emergency medicine attending and trauma team leader at Hôpital du Sacré-Cœur in Montreal, Canada.
Now, you had an interesting case that we discussed about by email. We're often in conversation with interesting stuff in resuscitation, and I found this one would be perfect for the show. Why don't you present the case to us first, Mathieu, and then we'll go from there.
Yeah, sure. So I reached out to you a couple of weeks ago to share a very surprising clinical observation to confirm mechanical capture during transcutaneous pacing, and you've been kind enough to invite me to share with the EMCrit community. So what we're doing today is a case report, right? N equals 1, but I believe it's a case worth sharing. I'll oversimplify the case because all the details aren't relevant to the main message, but it was a middle-aged, very comorbid female who arrived severely bradycardic. Her rhythm was a ventricular escape rhythm at 15 to 20 beats per minute without atrial activity. The blood pressure was unrecordable by automatic cuff, but the 15-20 beats per minute were producing a palpable pulse, and she still had some signs of cerebral perfusion. She certainly wouldn't do maths, but she was still opening eyes to voice. She didn't look great. In fact, she looked like she was going to arrest in the next minutes. I did what I rarely do and called for transcutaneous pacing while giving a fair trial of pharmacological pacing with a push dose of epinephrine, to which she had basically no response. And this is where things got interesting. I started transcutaneous pacing and quickly saw the SAT probe picked up signal with a good waveform at the rate at which I was pacing her. I assume I had mechanical capture because that's the traditional teaching, right? A good SAT waveform that follows the pacer rhythm equates mechanical capture. And if you think about it, it makes sense. One would think that the only way to get a good SAT pulse signals is a pulsating arterial flow at the tip of the finger or wherever the SAT probe is. So I thought I had mechanical capture, but while I was grasping for the ultrasound to study her heart, my colleague, who was literally just walking by, decided to check her femoral pulse for some reason. In fact, he probably decided to check it because the patient still looked like crap and he was wondering if she was still alive. That's when he told me that my patient was still severely bradycardic, and I must admit that she clinically still looked like a dying patient. I told him that was impossible, pointing to the pulse ox that was going at 70 beats per minute. Then I echoed her heart, and I was shocked to see that he was right. The patient was still in this super slow ventricular escape rhythm. I thought that was super interesting, but in the short term, I still had a patient to stabilize, so I went up on the output, quickly got real mechanical capture. The patient got clinically better, and she was transitioned to a transvenous pacemaker. Thinking back about the case, it seemed to me like a pretty important observation to share that even with a good waveform, the pulse ox isn't a reliable method to confirm mechanical capture. Thinking that you have mechanical capture when you don't is a disaster. Now, how can we explain what I witnessed?
All right, so I'm going to summarize for the listeners so we have the real physiologic rubric by which we're working here. This is a patient who is going 15 to 20 times a minute. You started transcutaneously pacing the patient. You had what might have seemed like electrical capture, I imagine. That huge disturbance in the EKG on the monitor makes it almost impossible to say one way or another. But did you guys think you had electrical capture, Mathieu?
Yeah, almost immediately. As soon as we started the transcutaneous pacer, we saw the electrical capture. Then I went up on the output a little bit until I saw the SAT probe picked up. Then at that point, I thought I had mechanical capture.
All right, so we have electrical and the vision of mechanical based on the pulse oximetry, pleth. And we've taught traditionally for transvenous pacing that if you have a good waveform on your pulse ox, you're done. That is mechanical capture. And that's never failed myself or any others. I can't even remember the time I've done transcutaneous pacing and cared. So I've never run into the situation we're dealing with right now, but I would have assumed before your case that transcutaneous pacing would also have been indicated positively with mechanical capture by the pulse ox. Now, you actually had a beautiful waveform on your pulse ox at 70, correct?
Yes, and that was the very surprising part.
All right. So we got a waveform. We have electrical capture. We have a vision of mechanical capture. Someone comes and says, nope, the actual proof of the fact that their pulse is still going 15 to 20 shows that pulse ox is lying. And you then confirmed it with an echo that showed that same 15 to 20. So we clearly have now a discrepancy. We have a pulse ox waveform and we do not have mechanical capture. And you were able, by raising the amperage, to eventually get mechanical capture. But there was a point in time where the pulse ox was showing a vision of mechanical capture that was not existing in reality. And now you had written me with some conjectures about why this could be occurring. But we will say these are just conjectures and it doesn't matter. It happened. You confirmed it. It wasn't just the pulse. Maybe someone's fingers were erroneous, but no, you confirmed it with echo, said the same thing. So now we know this is an objective reality. And now we're just trying to bandy around hypotheses as to why. So what were some of your conjectures?
As you say, we can only hypothesize about it. But what is for sure is that there was some pulsating blood flow at the tip of the finger, and that this pulsation at 70 beats per minute wasn't generated by the heart. The only explanation seems to be that the contraction of the upper chest wall and upper arms muscle that come along with transcutaneous pacing must create some pulsatility in the vessels. And that's not so hard to believe. If you ever witness transcutaneous pacing, sometimes the whole patient seems to be contracting each time the pacer fires. Now, was the pulse ox picking up arterial or venous pulsation? I don't know. It was reading in the low 80s, so it is still conceivable that the pulsatility was from muscle contraction on a very congested venous system, but that is speculation.
All right, so we have two possibilities here. One, we know we need pulsatile flow in order to get a pulse ox waveform, but it could be venous pulsatility. Now, you actually have pointed out that anesthesiologists have observed in severe tricuspid regurg that there will be the possibility of venous pulsations generating a pulse ox waveform. And where do you actually come across that, Matthew?
Going through the literature after the fact, I realized that venous pulsation artifact definitely is a thing. As you say, it's mainly in the anesthesia literature. The most extreme cases of it are the severe tricuspid regurg patient, but it's even in Robert and Edges. So it's definitely something that seemed to have been well known for a while.
Yeah, and I looked into this as well after your case, and it could be seen in tricuspid regurg. It could also be seen in patients with vastly open vasculature. For instance, the profoundly vasodilated patient. This is deemed a possibility. Okay, so that's one possibility. And then you had said maybe it is venous pulsations and it actually is picking up arterialized venous blood. And you had come across another set of possible confounders that I had never seen, though now, having looked at the literature, it makes complete sense. But you had actually found that on patients who are hyperoxic, on profoundly high levels of FiO2, that their venous blood could actually get erroneously elevated by increased oxygen levels on the arterial side. Speak a little bit about that, Matthew.
Okay. That discussion came from the fact that you pointed out that past a certain, that raising the FiO2, once you reach a high SaO2, doesn't have a huge impact on the SVO2. And that's the classical teaching, right? That the three main factors impacting the SVO2 are the cardiac output, hemoglobin level, and the SaO2. And to be fair, in most circumstances, that is true. But that is forgetting the second part of the equation of the arterial content in oxygen, which is the dissolve of O2. That's the 0.003 times the PaO2 that we all learn in med school at some point. In patients who have dramatic variation in their PaO2, that second part of the equation might have a non-insignificant impact on the SVO2. For example, the case that wouldn't be that rare would be the patient with profound hypoxemic respiratory failure who gets intubated and placed on a FiO2 100% and left there for a little while. Then the PaO2 before was maybe 50 and it's maybe 250 now. So that variation in PaO2 will certainly have a non-insignificant impact on the SVO2, especially if the contribution from the first part of the equation is lower for some reason, for example, lower hemoglobin level or a low cardiac output. Then it's been shown in empirical studies that the variation that it may cause a variation of the SVO2 of up to 10 to 15% in some cases. So that is certainly not insignificant. So it can give the appearance of an arterialized venous blood, as you pointed out.
Yeah. So I looked at the paper you sent me, and then actually there was an additional group from an entirely different country that had done the same experiment and had the same results. Now, so there you go. There's empirical objective evidence. Now, what they are saying as their physiologic justification is completely untrue. It's not possible. It doesn't work that way. Because regardless of what your dissolved oxygen is, that gets burnt through after the first exposure to tissues. And then you're completely reliant on the oxygen carrying capacity of your hemoglobin. So it really does not matter what your dissolved oxygen content is in normal physiology. But they observed what you described twice in two separate studies. So we have to accept that as reality. So in my vision, the only way to justify what they observed is there has to be arteriovenous shunting. It's the only way it could happen. And now this is actually profoundly interesting. It has interesting facets even beyond your case. But if that really is the case, that elevating up the FiO2 and therefore the amount of dissolved oxygen, the PaO2, right as it comes off the lungs, has effects on our mixed venous sat, it has profound implications in ascertaining that number on patients who are hyperoxic. And since I do believe these two trials, I do believe it's happening, I believe there is, therefore, in a variety of conditions, the possibility of arteriovenous shunting at the post-pulmonary point. We're talking about direct arterial to venial shunting. And that's been described in the literature. That does exist in some states, especially severely septic states. And if that really is the case, it means mixed venous cannot be used as an accurate rendition if you have your patient hyperoxic. And it does support if you had put this very sick patient on 100% FiO2, or to be physiological about it, 1.0 FiO2, that maybe that was what you were seeing. Maybe you were seeing an increased venous oxygen saturation as a result of that elevation of the FiO2. What do you think about what I just said, Matthew?
That is very possible. I think that everyone agrees, and for a little while now, that there is some regional shunting in different critical state, as you say, especially sepsis. And as I said earlier, I left out some of the details of the case, but that was a severely comorbid female with advanced liver disease, and she was also critically septic at that point. So she certainly could have had some regional shunting going on at the microcapillary level.
That's okay. And again, we're just conjecturing, but this is getting interesting now. So we have the severely septic patient with a ventricular escape rhythm. She has severe contractions of her musculature, as you see with anyone on any modicum of amperage on their transcutaneous pacing. So the conjecture we have here is that possibly she was getting venous pulsations of a sufficiently oxygenated degree of blood that you would have an 80-something% saturation on your monitor with simple muscle contractions generating that pulse ox waveform.
Exactly. I think that the possibility that there was arterial flow is also on the table. Muscle could have created some pulsatility in the arterial system as well. But I think that we have to consider the possibility that that was a venous pulsation.
Yeah, what was her pulse ox after you got mechanical capture, and therefore ostensibly we were seeing arterial blood?
That's a good point. Then it went up in the 90s.
But I guess the take home is, what are you going to do now to ascertain mechanical capture when you are transcutaneously pacing?
So I believe that the bottom line is that there seems to be a pitfall in assuming mechanical capture based on the pulse ox during transcutaneous pacing, even though that's in every textbook. The gold standard is probably ultrasound. I believe that there's no other reliable way to confirm that you have mechanical capture than to directly looking at the heart.
Or looking at the carotid or femoral vessels for an actual ultrasound pulse, I think you're fine with as well. Would you agree?
Yeah, totally. Yeah. Totally.
All right. Is there anything else we should say about this before we leave this incredibly interesting case?
I don't think so. Thanks for inviting me on the show. You saved me from having to write that as a case report.
Oh, no, we're putting this out publicly that this would be a shame and a travesty to the medical literature for you not to put this out as a case report. So I think you're now obliged by public shaming to actually write this up or have one of your residents do that.
That always takes 10 times the amount of time that it should.
But the textbooks won't change merely by an EMCrit We episode. So really, if you cared about medicine, and I know you do, you should write it up.
Yeah, so if one of my residents is listening, is interested in writing that as a case report, please reach out.
Yeah, or if any of the EMCrit listeners are super eager to work with one of the most brilliant Canadian trauma and resus doctors on this, reach out to him. Maybe we could put his Twitter information in the show notes.
I think that's perfect.